Hello everyone and welcome to our module on gaze palsies. Conjugate gaze refers to movement of both eyes at the same time in the same direction. You need your conjugate gaze in order to look right or left with both eyes for things like tracking objects. And when a patient develops a conjugate gaze palsy, this means that the eyes cannot move together in the same direction, and this results in diplopia when looking in one direction or another. In order to understand conjugate gaze palsies, we need to review the neural circuitry that's involved in looking to the right or left with both eyes. So in order to do this, let's imagine that we have a right eye and a left eye, and let's imagine that we want to look to the right. In other words, we want to look in this direction. This process will begin in a structure in the brainstem called the PPRF, which is the paramedian pontine reticular formation. This structure will send signals to the nucleus of cranial nerve 6, the abducens nucleus. That nerve innervates the lateral rectus of the right eye, so it will move the right eye to the right, which is what we want to do. However, we also need to activate the medial rectus of the left eye. In order to do this, there are nerve fibers from the cranial nerve 6 nucleus which can activate cranial nerve 3 for the opposite eye, and then cranial nerve 3 will activate the medial rectus. The nerve fibers that carry those signals to cranial nerve 3 of the opposite eye are called the medial longitudinal fasciculus, and this is a very important neural pathway for conjugate gaze. Here's a slide from our brainstem module showing you the anatomy of the pons. I just want to point out to you that cranial nerve 6 is located here and travels in this direction. It is surrounded by cranial nerve 7. Just inside of the nucleus of cranial nerve 6 you can find the medial longitudinal fasciculus fibers, and right next to those you can find the paramedian pontine reticular formation. So just to summarize the key points about conjugate gaze, the PPRF initiates lateral gaze from the brainstem. It's located in the pons. The medial longitudinal fasciculus carries signals from the PPRF to cranial nerve 3 on the opposite side, and conjugate gaze requires functioning cranial nerve 3 and cranial nerve 6. Now that we understand that circuitry, let's talk about our first conjugate gaze palsy, and that is an internuclear ophthalmoplegia. This is a horizontal gaze disorder. It's a problem with the eyes looking to the left or right. It involves weak adduction, which is medial movement of one eye, and the affected eye cannot move towards the nose because of weak adduction. The unaffected eye develops nystagmus, which we'll talk about in a minute, and this problem is caused by lesions of the medial longitudinal fasciculus. When you have a lesion of the MLF, the clinical syndrome you develop is called an internuclear ophthalmoplegia. Importantly, convergence is usually spared, so patients who have an internuclear ophthalmoplegia can't look left, they can't look right, but if they try to look to the middle with both eyes, which is convergence, that is usually normal. That's because it has a different neural pathway, and cranial nerve 3, which innervates the medial rectus muscles for both eyes, is working properly, and therefore convergence is okay. To make this more clear, let's consider the example of a patient who has a left internuclear ophthalmoplegia. This patient will have eyes that are midline at rest, and when the patient tries to gaze to the left, everything will be okay. In other words, if they try to look left, the right eye will move left and the left eye will move left, and everything will appear normal. However, when this patient attempts to gaze to the right, there will be a problem. The right eye will move to the right as it should, but the left eye will not move medially past the midline. That's because there is a problem with the medial longitudinal fasciculus, and thus we say this patient has a left internuclear ophthalmoplegia. If we go back to this slide, a patient with a left INO has a problem with the MLF fibers that innervate cranial nerve 3 from the right side to the left side of the body. When this patient attempts to gaze to the right, the lateral rectus muscle will be activated as it should, and therefore the right eye will move laterally. However, there's a problem with the MLF innervating cranial nerve 3 on the left. Thus, cranial nerve 3 will not receive its normal signal, and it will not activate the medial rectus muscle. This means the left eye will get hung up and will not move medially past the midline. And I've summarized these points at the bottom of the slide. You need your MLF to move the eye medially when the other eye goes lateral. The side that cannot go medial is the side with the MLF lesion, and when there is a problem looking to the right, this means there is a left MLF lesion. Just to make this point even more clear, I've shown a series of eyeballs on the screen to help you understand a left and right INO. So a normal patient has eyes that are midline at rest, and the patient can gaze right normally and can gaze left normally. A patient with a left INO will have eyes that are midline at rest. When they attempt to gaze to the left, that is normal. However, when they attempt to gaze to the right, one of the eyes is hung up and cannot move medially past the midline. A patient with a right INO has the opposite findings. The eyes are midline at rest. When they gaze to the right, that is normal, but when they gaze to the left, one of the eyes cannot move medially past the midline. An internuclear ophthalmoplegia occurs because of damage to the MLF. This is sometimes referred to as an MLF syndrome. This involves lost MLF input to the oculomotor nucleus on lateral gaze. The AD ducting eye, the eye attempting to move medially, will be unable to do so past the midline. You should also be aware that the other eye, the AB ducting eye, will develop monocular horizontal nystagmus. Nystagmus is repetitive eye movements, and this occurs because the eye moves smoothly laterally, but then the brain recognizes that the eyes are out of alignment, so there is a rapid movement back to the midline. This is called a saccade, and this leads to the development of rapid eye movements, which are called nystagmus. So if you look at the bottom of the screen, what happens on lateral gaze in a patient with an MLF syndrome is that the AD ducting eye has no movement past midline, as we saw on the last slide. The AB ducting eye develops nystagmus and saccades, and that's because it moves laterally, gets out of alignment, and then is jerked back towards the midline by the brain. The most important cause of an MLF syndrome for you to be aware of for step 1 of the boards is multiple sclerosis. The MLF is highly myelinated, and thus when demyelination occurs in multiple sclerosis, an MLF syndrome can develop. Another neurologic problem that can sometimes be confused with an MLF syndrome is an abducens or cranial nerve 6 nerve palsy. This problem also produces a gaze disorder, but it has different features from an internuclear ophthalmoplegia. If we go back to this slide, when you gaze in this direction, you need cranial nerve 6 to innervate the lateral rectus muscle and move the right eye laterally. So if there is a palsy of cranial nerve 6, one of the eyes will have difficulty moving in the lateral direction. To understand this better, I've once again shown a series of eyeballs on the screen. So at the top is a normal patient with eyes that are midline at rest and eyes that can gaze to the right and also gaze to the left normally. In a left abducens nerve palsy, the left eye may be pulled medially because the lateral rectus muscle is not functioning normally. It depends on the severity of the lesion. But whether the eye is medial or not, the problem will get worse on horizontal gaze. When the patient gazes to the right, that will be okay. But when the patient attempts to gaze to the left eye will not be able to move laterally. That's because of the cranial nerve 6 nerve palsy. In a right abducens nerve palsy, the findings will be the opposite. So the key points I've summarized at the bottom of the screen. You want to look at the eye that is stuck. Is it trying to move medially or laterally? If it's trying to move medially but cannot, then that patient has an internuclear ophthalmoplegia. If it's trying to move laterally but cannot, then that patient has a cranial nerve 6 palsy. Let's talk about some other lesions of the conjugate gaze system. Let's talk about what happens if there is a lesion involving the PPRF. This will lead to an ipsilateral gaze palsy. In other words, there will be paralysis of conjugate gaze to the side of the lesion. The patient will not be able to look toward the side of the lesion. That's because the left PPRF coordinates leftward gaze. There will be preservation of convergence because that's a different neural pathway. And this can happen when there's a medial pons lesion. If you look at the brainstem image at the bottom side of the screen, if you've got a lesion involving the medial pons, that can damage the PPRF. If we go back to this slide, if there's a lesion that takes out the PPRF, you basically won't be able to initiate gaze toward that side of the body, and therefore you will have a conjugate gaze disorder when trying to look toward the side of the lesion. We talked before about what happens if there's a nerve palsy involving the abducens nerve or cranial nerve 6, but what happens if there's a lesion in the brainstem involving the nucleus of cranial nerve 6? Well, this will lead to findings that are the same as a PPRF lesion. There will be loss of lateral gaze on the side of the lesion. That's because the PPRF activates the nucleus of cranial nerve 6, which in turn initiates lateral gaze towards that side of the body. Back to this slide once again, the PPRF activates the nucleus of cranial nerve 6. If there's a lesion that takes out this nucleus, then that will be the same as having a lesion to the PPRF. You will not be able to initiate lateral gaze towards this side of the body. The 1.5 syndrome is a gaze palsy that can occur when there is damage to both the PPRF and the MLF, and this can happen because these structures are located close to one another in the brainstem. Patients with the 1.5 syndrome develop an internuclear ophthalmoplegia plus loss of lateral gaze to the affected side. To understand this, let's look at the bottom of the screen where I've shown what can happen with a left 1.5 syndrome. When a patient with a left 1.5 syndrome looks to the right, they will develop symptoms of an internuclear ophthalmoplegia. That's because there has been damage to the left MLF. Thus, when they gaze to the right, the left eyeball does not move medially past the midline because the MLF on the left is not working. In addition, when they look the other way, in other words, when they attempt to look to the left, they develop a conjugate gaze palsy. This is because the PPRF on the left side has been damaged, and thus they cannot initiate gaze to the left side of the body, and that's called a 1.5 syndrome. Our final gaze disorder is different from all the others we've been talking about up until now because it involves the cortex and not the brainstem. So the PPRF and the cranial nerves and the MLF and the structures I've been talking about to this point are in the brainstem, but they are controlled by a portion of the cortex called the frontal eye fields. This is found in the frontal cortex in Brodmann Area 8. Shown on the screen is a map of the Brodmann areas of the brain. Area 8 is here in the frontal cortex, and it contains projections that go to the contralateral PPRF and are important for coordinating horizontal gaze. To understand lesions of the frontal eye fields, you need to appreciate that normally your gaze is kept central due to equal FEF activation. In other words, if you look at this normal example of two eyes on the screen here, the reason the two eyes are centered is because the right and left FEF are both activating the eyes equally. What this means is when you have a lesion, you remove the activation from one side and thus the other side dominates, and this means both eyes will deviate to the side of the lesion. So for example, in a right FEF lesion, the left FEF is still working and it will push the eyeballs towards the right. Interestingly, if you stimulate the FEF on one side, both eyes will deviate to the opposite side, and this sometimes happens in frontal lobe seizures. The right or the left frontal eye fields are heavily activated and they can push the eyes towards the opposite side from the side that is involved with the seizure. I'll finish with this table summarizing the different gaze palsies we've reviewed in this video. In an MLF syndrome or an internuclear ophthalmoplegia, the eye on the affected side can't move medially, in other words, can't perform adduction. In an abducens nerve palsy, the eye on the affected side can't move laterally, in other words, can't perform abduction. In a PPRF lesion, you cannot initiate gaze toward the side of the lesion. In a 1.5 syndrome, patients develop that complicated internuclear ophthalmoplegia and lateral gaze palsy on the side of the lesion. And then finally, in a frontal eye field lesion, the eyes will be deviated toward the side of the lesion. And that concludes our module on gaze palsies.